This is the native papilla. Now, before we do any procedure, because she's got PSC pattern, we need to know her coagulation status, which I'm told INR is 1. Because we won't be able to drain all the ducts, we have to give her antibiotics. The question is that, with the stones in the intrahepatics and so on, I am inclined to do a sphincterotomy. This is the Olympus sphincterotome, the clever cut. If you see, the end of the wire is covered with an insulation plastic and the cutting wire is at the other end. So we cannulated the bile duct with a guide wire. I had to use a 025 guide wire to get selectively in the bile duct. And then I'm going to do...
Can we see the fluoro with the endoscopy, please?
Let me cut this first. You can keep the endoscopy view. So if you notice that insulated part of the cutting wire is protective against cutting any side folds that we may have. Flex a little bit here. So it's not like we are pulling out a big stone, so I do not have to do a large sphincterotomy.
Do you change the settings for sphincterotomy, or do you have any preference?
Yeah, it is. We have the ERCP machine here. It is already preset to a papilletome effect 2 endocut. So we are on a papilletome setting at 2, effect 2 endocut. And it's always the yellow pedal. So I think I don't want to cut more than that, but now it's a kind of like nice bloodless cutting. The bile doesn't look to be infected, it looks to be clear bile. But now what is interesting is that, can you relax this? That if you go now to full fluoroscopy picture, go to the fluoroscopy picture. No, on the monitor there for the audience. Now if you look at it, I don't know whether you're getting a good view or not, but I very gently injected. I don't want to over inject because I will not be able to drain all the system here. So fluoro. Initially, we were finding our guide wire was going into the cystic duct. With some manipulations, I flipped it into the left duct now. Now, if you inject here, and you see how it fills up there. See, that is not just left, it is a right and left bad PSC pattern. And that is the kind of, don't want to overdo this, but I'm not sure whether we'll achieve any successful drainage. It's a very sort of multiple strictures on the right. We don't want to infect it. We can't be putting stents all over. And the guide wire is on the left side, but whenever we push it, it hits the stricture and it buckles and comes down. Try pushing the guide wire up again. I don't know whether you can see the guide wire looping in the left system.
Yeah. Any particular wires you prefer in these kind of cases?
This is a 2.5 Jaguar I have. We had a 3.5 VisiGlide before. It was not going in easily. Kept going into the cystic duct. Then I had to advance. So when the wire keeps going into the cystic duct, even though the contrast are going into the intrahepatics, you can pull the sphincterotome down into the common bile duct, bend the sphincterotome, or pull your scope back and flip the sphincterotome to the opposite bile duct wall and keep trying the wire in and out. In this particular case, nothing of that was working. So I, with free hand, took the sphincterotome up to the common hepatic. So the sphincterotome tip is thicker than the wire. So the wire was selectively going in the cystic duct, but the sphincterotome went up into the common hepatic. And from there, I flipped the wire into the left system. But now my problem is that I can't get anything past that area of stricture. Both sides, intrahepatic duct is quite diseased. So rather than keep trying and giving her a problem, she definitely will need to be on antibiotics. The question was that, should we just brush her and go from there? Putting in a spyglass and trying to figure this out. With spyglass, there is a lot of saline injection, and I've had at least 2 cases who developed a liver abscess after spyglass, trying to biopsy stricture in the common hepatic. So antibiotics becomes a must, but what do you think we should do now? I mean, we can keep trying the wire, or let me just, can you fluoro? And let me see.
So what was the target
You see the
system,
wire is on,
Dr.
the
Dua?
wire is on,
She has
sorry?
the dominant stricture in the right or in the left hepatic duct?
Both sides. Okay. If you look at the right system, if you inject a little bit here, inject. If you just watch this thing, fluoro, yeah, inject. If you are you watching how the yeah, keep injecting. The gallbladder is filling up selectively. Contrast is hitting the hilum. Stop. And I mean, I can see a better fluoro picture here than on the screen on the monitor. It's a mess on both sides. Multiple strictures, right and left. I mean, this is like a bifurcation stricture at the top. And the contrast hits that area and comes down and goes into the gallbladder.
So there's a question, Dr. Dua. So, Dr. Muhammad.
You illustrated a very important point that when you have PSC, multiple stricture, try not to overinflate because you are going to cause septic cholangitis.
Exactly. Yeah.
This is very important. But your position of ERCP is looks. Can you
no, I
shorten
had to
or?
Yeah, no. I had to. The scope is very short. It will fall in the stomach. But I had to use this position to get into the left system. But now, if you notice, if you fluoro, yeah. And now you look at my scope. So that was the position we tried to get deep cannulation in the bile duct. Now in this particular position, which is kind of like the typical hockey stick position, very short position aligned against the papilla, and I can shorten it even more. If you look at my endoscopy view, now fluoro. So that is kind of the short position there. But it changes nothing. You can try the wire again.
So we have this case.
Yeah, we are trying to get the wire up.
Yeah, well, I think it also depends on before the procedure. I mean, if the patient is obstructed with high bilirubin, then maybe I would go with the SPY. But maybe if she's not obstructed, I don't know, repeat image just to really define if she really has a dominant stricture or just the PSC.
Fluoro. What I'm trying to also do is to see if I can take my sphinctertome, fluoro.
Yeah,
up there,
I mean,
I'm way up in the hilum. Now inject, very gently inject. I don't want to over inject.
Yeah, I think if you keep
Yeah.
pushing the wire, try to push, maybe it will go to the right
So-
system now because it's taking
Yeah.
a curve.
Yeah. No, I had selectively gone to the left because the MRCP kept saying dominant left with stones.
Oh, I see.
So we got the, it is sometimes easier to get the right than the left, but if you get the left, especially if you are putting bilateral stents, the left turn, if you get the wire on the left side, keep it, don't lose it, and then go to the right with another wire. But in this
Absolutely.
particular case, I think in this particular case, what we can do is that just for brushing purposes, I'll pull my sphinctertome a little bit back, fluoro. Yeah. And pull the wire back in the sphinctertome. I'll lose the left, pull it back. Pull the wire back in the sphinctertome. Pull it back, pull back, pull back. Okay? Now go forward. Push it now. Yeah. Yeah. Pushing.
Yeah. Left hepatic duct, Muhammad. Seems
Yeah.
to be the dominant stricture, left hepatic
Yeah,
duct.
go.
And
Go,
the
go,
rest
go,
is
go.
more like a PSC. That's what the
Yeah,
MRCP.
see now it has gone to the right.
Yeah, it
Stop.
will
Yeah.
flip
Now
probably
if she,
even to the left.
yeah, now see it is going to the right, but if she pushes more, it will flip into the left.
Yeah.
Push more. You see how it will knuckle into the left. Oh, this buckled into the right. Okay, this is gone. Now this is, that, as I said, right is easier to get, but the wire is, do you think this is a 2-5 wire? Do you think changing the wire will make a difference?
I will go with the angulated wire and see if that will help.
I mean, no, I mean, angulated is good to get into the right and left. Over here, we are getting, I was in the left, now I'm in the right. Question is that the wire is 2-5 wire, it is very floppy. So it hits the stricture and it flips and comes back. Do you think like a stiffer tip, like a 2-5 VisiGlide will do better?
Yeah, I think so. It's worth a trial. I mean, you have the 0.025 now. You may go just with the 0.035.
VisiGlide. We had already opened it here. Try the wire
I mean, for this case, I think if there is a proven dominant stricture in the MRCP and the wire is difficult to pass, I think it's very reasonable to use a spyglass. If it is a clear dominant stricture, it will be probably even the best way even to place a wire will be the direct visualization with a spy. I don't know what the other audience and moderators think.
What do you think about this biliary hepatic?
Yeah.
It's too thick, I think.
Yeah. Let's try the 3-5 VisiGlide. Yeah.
And interesting, we can see the dilated cystic duct and gallbladder. It's probably just from her extrahepatic biliary strictures causing back pressure to the cystic duct and the gallbladder. So while you change,
there are two questions over here. One question is whether we are looking for tissue to rule out cholangio. I'm not. I mean, she's 27. Anything can happen. And the second issue is bile duct drainage. So now you see we're using the VisiGlide and it's doing the same. This is the 3-5. And it's doing the same thing. So I think from endoscopy perspective, getting adequate drainage in her will be very difficult. In the attempts to get drainage of the right or the left system, we may infect her with contrast and attempting again and again. So endoscopic drainage is going to be a bit of a problem here. What else would you think?
Yeah, I mean, I don't know if her bilirubin is elevated. Probably, I don't think so. That her bilirubin or she is really obstructing. So maybe drainage will not be the aim more than just diagnosing a dominant stricture with a direct biopsy. I mean, maybe going in with a quick look with the spyglass, just to make sure there is really no ingrowth in the left hepatic duct with that dominant stricture.
Yeah, I was told that for today they would want me to brush her, and then maybe they don't do fish analysis here, I'm told, but we can definitely.
It's reasonable as well. I mean, if you keep pushing the wire, probably will go back to the left system, and then you'll brush the left system. Especially if she's not obstructed, I don't think it will be a malignancy. I mean, with normal bilirubin, it's very unlikely, I believe, that patients will have cholangiocarcinoma. But maybe brush for now, and then spyglass next time will be also a reasonable approach.
I mean, that's what I was told for time's sake, that we just do the brushings today, and there is a less than 30% chance that the brush will show us anything positive. But then if there is a concern, maybe spyglass is the next way to go, with the provisor that we will increase the risk of infection with all the saline and all we inject. But I suspect with the sphincterotomy, most of the saline will back flush out into the duodenum rather than go into the intrahepatics. I mean, currently the contrast preferentially is hitting the hilum and coming back in the gallbladder. So spyglass is possible. So if you want to continue with the other rooms, I'll just brush her.
Okay,
and then leave it at that, and then spyglass for next time.
Thank you very much, Dr. Dua. So we can switch to another room if any patient's ready.
Yeah. So push the wire up. Is this stop? Is this relaxed? Yeah, push the wire. So have you noticed over here what I did? I took the brushings, but then I took a forceps. I've taken a forceps. If I show you my endoscopy view, I took a forceps in the bile duct directly without the wire from the side. So now I'll be taking biopsies from the hilum with the forceps. Open, open. Okay. And now if you notice that, look at the fluoro picture. I'm taking biopsies close, close, tight. Okay. And now I've taken biopsies from the stricture, and I'll take one more biopsy. So sometimes they have shown that brushings with direct biopsies, if you are not doing cholangioscopy, is better than just brushings.
Was there any special technique to advance the biopsy forceps?
I'll show it to you. I'll go in again. I'll just show it to you. So so if you do not have a wire-guided, this is not a wire-guided biopsy forceps.
That's right. Yeah.
This is just a freehand cannulation of the bile duct with the forceps. I mean, this is a forceps, regular forceps. You go from the side of the wire, as you normally do, and then you come out. You see the direction of the forceps, it goes this way. So you make it short like this, and then take your scope and bring it to the top, like this over here, and there you go in. See that? Now I'm inside. There, I'm fully inside, there. Now, if you look at the fluoro, and there is a forceps going to the hilum, open, open. So when she opens, I push forward a little bit. There I am hitting the stricture, close, tight, okay, and there is a forceps there.
Are you using the regular forceps or pediatric forceps?
This is from Microtech.
Yeah, I think this is a pediatric from the color.
Yeah.
Pediatric forceps. Yeah.
Is it possible to use the spyglass biopsy forceps?
Yeah, so I did the brushings already. Okay. I don't know if you want to show the full endoscopy view. I can show the technique of putting a forceps.
Yeah, that was nice. We saw that. I mean, that was.
You saw that,
yeah.
Yeah,
absolutely.
I think then, yeah, we are done here. We took biopsies, we brushed it, and let's see what it shows. Then the next step would be spyglass.
Any need for dilatation?
Maybe I'll take one more.
There was a question, Dr. Dua, is there any need for dilatation or stenting at this point?
The problem is that the intrahepatic ducts and the hilum are so obstructed that, I mean, the extrahepatic area doesn't look to be critically narrowed. I mean, the forceps can go up, and the brushing catheter that they gave me was also very thick, and that also went up. So the extrahepatic, see again I'm into the bile duct here, yeah, fluoro. So, I mean, the open. What is interesting is that, close, except for one segment on the right side, all the ducts drained out. If you look at the fluoro picture now, the cystic duct and the gallbladder still have contrast, but the ducts from within the liver, I think the one system on the right is not draining because of her lying in the prone position. If you turn the supine, it may also drain. So I don't know whether it is any point in, see, once you start putting in hardware in the patient, once you start putting in plastic stents, then she will have to come again and again and again for stent exchanges.
Yeah.
So the question
I think that's yeah. I mean, the wire doesn't really go freely, and I think there's no point to put a stent, especially if there is really no post stricture dilatation as we saw. And it will just keep causing more trouble, I think, in patients with PSC. So I think post-procedure antibiotics for a few days and follow up the biopsy and the brushes will be the way to go.
Yeah. I think we'll stop here. We recommend giving her antibiotics for another at least 5 days. And hope we get some answers. I mean, the thing is, what are we expecting from the brushings? I suspect it will not give you a diagnosis of cancer because I don't think there is cancer, and the brushings will only show chronic inflammation.
We conclude.
But sometime when they do liver transplant, they found those patients, they are harboring malignancy, cholangiocarcinoma,
Yeah.
even if they are not by
And
biopsy.
there is no bleeding, nothing, looks fine.
What do you think? Wash with the serum because they have cholangiosis and we inject lots of
What was saline?
saline, yes.
I don't know, I have not done that. One suggestion that is coming up here is that should I just do a saline flush to wash her out? I think most of the ducts have drained already, and the sphincterotomy will drain the common hepatic and the common bile duct. The only thing that is not draining is the gallbladder, which I don't know when the very rarely, if there is any doubt that this could be autoimmune, people take ampullary biopsy to look for plasma cells. That was one of the ways, instead of taking core biopsies, say from the pancreas and so on, like we had a case in the past, people used to take ampullary biopsies to look for plasma cell infiltration, just in case this is autoimmune cholangiopathy, which is more in the older population we see, not at this young age. I do not know her history of colitis. Does she have any history of any inflammatory bowel disease? That is another thing that one will have to look into.
Any preferred antibiotic, and for how long?
5 days, at least.
What do you prefer? Cipro? What antibiotic?
Any suggestions from anybody, or should we just close?
Yeah, my suggestion, if this patient has primary sclerosing cholangitis and have these strictures actually, and sometimes the biopsy cannot tell us if there is a harboring malignancy or not. So it should be listed on the liver transplant, this man.
I think we are then done here. We'll wait for the biopsy results. We'll protect her against cholangitis as much as we can with antibiotics. And then if we got the biopsies, we got the brushings. And if we wanted targeted biopsies, then next step would be cholangioscopy.
What about the tumor marker of the patients?
A tumor marker, even if the CA19-9 is elevated, it can be elevated with biliary obstruction without cholangio. I think the longer issue with this patient is going to be like hepatology follow-up, and where does she go at this young age down the road. If she progresses, maybe at some point she will be listed for liver transplant. And of course, today it is like this. She's always at a high risk of developing cholangiocarcinoma. So many things in her follow-up that needs to be watched. And besides the fact that we have to rule out IBD, they may have no symptoms, and still if you do colonoscopy, you can pick up inflammatory bowel disease.
Any question? Talib.
All right, I think then we are done here.
Okay.
Thank you very much.
Thank you.
Always suck the stomach out. Otherwise, you will make your anesthesia people very angry.